So tooth resorption wise, you guys see these quite commonly. Half the cats, as we talked about, over 8, have tooth resorption, and half of those have more than one lesion. So that kind of puts it in perspective. That's a bunch of cats in your practice, especially if you have a feline practice. How many people have just feline? Yours is just feline. So you see that a lot. I'm sure all of us see that a lot. It starts off in the root generally, and then it extends into the crown. It may start at the crown-root interface and go both ways. This is a mandibular first molar on the right side, and you can see that lesion there in the mesial crown. The green, anybody know what that is? The green thing that's in that picture? That is the Christmas ribbon that this practice like to use to tie their endotracheal tubes. So there is the radiograph, and you've got significant crown destruction, but you can still see a faint periodontal ligament space around both those teeth. So that's an extraction. And we'll talk about type 1 and type 2 here. So this is a good image, although this is an old image. This is a good image of a tooth that's got both types of tooth resorption and one that's also got perio. So that tooth on the left side of the screen, 307, has a big defect in the crown. And you can see that on the tooth next to it, there's a zone of erythema that's pretty much parallel to the margin. And then you've got underneath, apically to that, you've got all that nice pink normal tissue. The reason why you've got that zone is that. You've got bone loss, got a big hole there on that tooth. So what's in that hole? Granulation tissue. So that's all inflamed, and that's why you've got that rim of inflammation that is equivalent to where that granulation tissue is, where the margin of the bone starts with the horizontal bone loss. So that is an extraction. There's no way to alter the progression of that unless we do a apically positioned flap like we did on that canine tooth and take all that tissue out and knock the bone down and have the owner come back to save that tooth, which is not really a significant tooth. So owners are not going to do that for the most part. And I agree with them. I don't think it's worth putting the patient under anesthesia every 6 months to maintain something like that for a tooth that's not a critical tooth. So that one is, the 08 is a perio case, that one's an extraction. On the tooth adjacent to it, on the 07, you've got the mesial root that's got a periodontal ligament space around it. It's pretty well defined. That is considered a type 1 because you can see that periodontal ligament space all the way around it, and consequently that, as part of your treatment for that tooth, needs to come out in total. So that needs to be a full extraction. On the other hand, the tooth, the distal root on that tooth, you can't see a periodontal ligament space. The bone's coming in and it's replacing the tooth root and obliterating the periodontal ligament space. And you get that kind of striation effect there as well that you see. So with that particular tooth, we can do what we in the past called a crown amputation, but we're in actuality not really doing a crown amputation. How many people are familiar with that term? So everybody's familiar with that term. Other than yesterday when I mentioned it briefly, who was familiar with partial extraction as the term for that? Okay, a couple of you. So that, I think that is so much more descriptive and not confusing, because if we do a crown amputation on that root, the crown is at the neck of the tooth coronally. So this is the crown. But the marginal bone has been compromised, so we've got horizontal bone loss, and consequently we've also got tooth root that's above the marginal bone. So if we do a crown amputation, all of that tooth root above the bone stays, right? By definition. And so does anything that's down in here where we've got that lucency in the root and extending into the furcation. So again, there's going to be granulation tissue in there. We're not just going to take the crown and leave all that stuff and suture the gum over the top of it, because that's going to cause inflammation, and it's going to come through the gum again. It's going to look worse than it did to begin with. So we want to do a partial extraction on that, removing everything above the marginal bone level and anything below the marginal bone level apical to that might be inflamed or might still be tooth tissue. So we would be going down to this level all the way across and removing all this, and then looking at that to make sure that there's no bleeding pulp, make sure there's no remnants of the pulp cavity. And that tooth is non-vital, but there might be some inflamed tissue that's in the pulp cavity that's a remnant of the pulp that we want to get out of there. And it's not going to go much further than halfway down that tooth root, but get it out of there just to be safe. Yes?
So how can you tell how far apically you have to go? Like if you're in there debriding, how do you know when you've got all the granulation tissue out and when the rest is resorbed and you're not going to get it? Like, how do you know when to stop?
It's a combination of radiographically and visual observation. So you want to be able to look at that on radiographs like you see there and say, oh, okay, well, this looks like this is a lucency all through here. I'm going to, before I even go in there, I'm thinking I'm going to remove that with my diamond football burr. And then once that's smooth, you look at it and it should all be smooth. You may still be able to see the outline of the tooth, but there's no pulp, there's no line of demarcation that's significant there, because, I mean, you can't see it radiographically, you're not going to see it grossly, and then you're done. I mean, it's just quick decision, quick and easy. Go in there, use your diamond football burr, radiographically, to where you see it radiographically, confirm it visually, and then you're ready to close it. All right.
Okay, one more question. I have
Yep.
seen another way there's a fracture on the crown. When you have fracture on the top. So is it a good idea to just do only crown amputation? Because I saw some vets they do only or you had to remove the whole.
No, because that becomes a fractured tooth. Whether it has tooth resorption or not, becomes a fractured tooth. So if it's a fractured tooth, it's either a root canal or extraction if the pulp's exposed, or if it happened today and the owner gets it in there today, it might be a vital pulp therapy, crown reduction, vital pulp therapy, but that's almost never. So then, you've got to extract it. It may just so happen to have tooth resorption as well, and then you manage it just like we're talking about right now. So fracture supersedes anything. I mean, before you even take an x-ray if you've got pulp exposure. So that is an extraction or a root canal. That's what you're thinking. And then you look at the x-ray and then you make that determination. All right, so this one's not as obvious as the one you just saw. That looks pretty good, right? Anybody see anything there at all that they'd jump on? So right there?
Yep.
Yep. Good call. So that little tan area right on the distal aspect of that distal crown, that makes you start thinking. So I am on. Okay. So that would make you start thinking there is some change there. And looking at it from that side, looks pretty good, right? Look at it radiographically. So there is no root there. It's been totally resorbed. And now you've got that lucency at the marginal bone level, so you've got really nothing to do except for clean that distal area up. The mesial root's got a periodontal ligament space all the way around it. So what you're seeing there is you had tooth resorption likely that was the original insult, and then because of the breakdown of the root, you get the bacterial ingress and the inflammation that produced this lesion as that tooth was resorbing. So kind of a perio lesion. You've got granulation tissue in that, but the long and the short of it is you don't leave that. You extract the tooth, and in doing so, with your flap being open, you've got access to clean that out, suture it back, and you're good to go. Now, what about those two other teeth there? Look at those. Tell me what you think about that.
Reevaluate the ear.
Yeah, I would buy that.
Because it's for like this is the problem I have a challenge with is it ankylosing or is it tooth resorption? And when it's the early, it's hard to tell between the two.
Good, Maya. Exactly. That's exactly what we're dealing with right there. That is not tooth resorption. And you look at that and you say, well, there's no periodontal ligament space there. But there's also good tooth density there versus what we just dealt with. I mean, there's no discernible tooth density on the distal root there, but there sure is on all those. So that's an older cat, and that's just ankylosis. That may result in, or that could progress when you have ankylosis anytime. Then you can get progression to external resorption, where the resorption starts on the margins of the tooth root and start to kind of eat a hole in the side. That usually happens in dogs. Doesn't happen a lot in cats. But those could certainly spontaneously have tooth resorption later, but it probably wouldn't be associated with the fact that there's ankylosis here now. So those are unlikely to be a problem. But just like any other tooth in the cat's mouth, when you have tooth resorption, you're going to get more tooth resorption, probably, depending on how old the cat is. So we usually monitor these guys every year to 18 months radiographically, depending on how the owner wants to approach that. The recommendation is going to be, again, based on how much other perio the cat has. You know, if it's got a lot of tooth resorption and a lot of perio, we might want to get them back every 6 months. We probably wouldn't take x-rays every 6 months, but we'd at least take x-rays yearly to see. And ideally, yearly is a good time frame. That being said, these can happen in 6 weeks. And there's some unpublished research for periodontal disease in cats where they use the traditional model that they use in mice, where they put silk ligature around the neck of the tooth and they induce periodontal disease, and then they do their studies on perio. They also do that in dogs, unfortunately. But with cats, silk ligature will produce tooth resorption in 6 weeks. So there seems to be some bacterial, periodontal, antigen, immune reaction stimulus to cause those odontoclasts to start destroying the tooth. So in theory, based on that, we do a little bit better at our home care, do a little bit better at getting these guys in more frequently to keep that plaque load down. We might be helping prevent tooth resorption. Now that's not, don't take that and write it down and say Beckman said this and this is always what happens. This is just in theory, just thinking about that model and thinking that, well, if you can produce it that quickly, then bacteria, inflammation, combination thereof, whatever it might be playing a role in some of these. So may be able to help out that way. So we talk to owners about home care and talk to them specifically about what we just said, letting them know that we don't know that that's the case, but it doesn't hurt, right? It helps anyway to keep the plaque load down for perio reasons, so anything's good to help that. So extraction, and could use a bone graft there, right? That's probably right on the margin of being too thin, and maybe lose a little bit of marginal bone if we just leave a blood clot in there. But that's still pretty cortical when you look at it. I would not put a bone graft in that one. But if it was much thinner than that, I would definitely consider it. So this tooth is the one that we get tooth resorption with most commonly. This is the third premolar in the mandible. Again, we don't have the first and second, we just have the third. And as long as that bump is there and it's not inflamed and there's no pathology radiographically, you don't have to do anything for that. But if it's inflamed, that means you've got some of that crown that's still there and causing inflammation under the gum line. It's extending to the epithelium. You want to go ahead and do a crown amputation, and in this case, usually it is a true crown amputation where you're going down to the marginal bone. You don't have to go much further, but not always, because we saw in that other patient, same tooth, just had to go a little bit deeper. But many times when you see this, it's just a crown amputation. So the canine teeth, not unlike the rest of them, we start to get that involvement with the crown. Gingiva grows into the area that's been destroyed by the resorption, and we start to get discomfort. By the time it gets to where that is on that patient, by the time we get to crown involvement, you've got, in almost every single case, and I can't recall any case that I've ever seen that this isn't the case, the whole tooth is resorbed already. It's usually type 2, unless you have vestibular bone expansion as well, which would be unusual to have extension onto the crown and vestibular bone expansion and tooth resorption. That's visible. Many of the cases with vestibular bone expansion are going to be like the ones I'm about to show you, where this starts on canine teeth and cats. And this is unusual. This happens just with the canine teeth. So before it even begins to get to that level, it may not be visible at all. So here's a couple images on the same patient. So that looks pretty good. I don't see personally any changes there that I would jump on grossly. Radiographically, what do you got? You start to lose the normal architecture about the apical third or so, maybe even up to the half of that tooth root. You got a nice tooth, discernible tooth structure the rest of the way, but then you get up there, it's kind of ghosting, right? That's how they start, and that's what it looks like generally. So pulp cavity diameter is fairly large. That might be a 4, 5, 6-year-old cat, who knows? But by the time that cat gets another 3, 4, 5 years old or less, that's going to be getting close to the crown or maybe even affecting the crown. So at this point, recommendation is to extract unless the owner wants to wait a little later for some reason, but this is going to be an extraction eventually. We don't want to wait until it's hitting, getting and affecting the crown and causing discomfort. We want to get it now, or we want to get it in a year or 18 months or 2 years, whatever time frame that might be, before it gets to be a problem. If this cat's 15, I'm not worried about that. That's not going to advance to the crown by that time. So you have to take into consideration the age of the patient and the extent of the resorption. Now, if this cat's 15 and he's healthy otherwise, and it's almost to the marginal bone level, then that's an extraction or a partial extraction, usually a partial extraction, because again, those are generally going to be type 2 resorption where you can't see a periodontal ligament space, and so you're going to remove the crown and whatever root has changes, and then you're going to suture over the top of that after you've smoothed it with your football work. Cherry?
So then, is it not generally painful until it gets to the crown?
Couldn't hear you, I'm sorry.
Is it not generally painful?
Yes,
until
as
it
far
gets
as
to
we
the
know,
crown?
they're not painful until they reach the crown. Same thing in humans. That happens in humans too, and it's not painful until it gets to the crown. So there's normal. So you've got that where you've got the ghosting. There's no real discernible tooth structure, and then you've got that where you've got very easily visible tooth structure all the way up, periodontal ligament space, nice and discernible. So that's a normal for contrast. And that lucency that's the half, that's just the air in the skull, nasal cavity superimposed over the image. That's normal. So same thing, other side. Doesn't look that bad, but that one's a little bit more pronounced. You see that a little better on that one. Again, there's normal. Another patient, where those arrows are, you've got a lucency. You start to get that striation effect. It kind of looks like wood, like you can imagine wood, splintering wood would look. So you start to get that striation effect. And when I approach, and I recommend to you guys when you approach these, something like that, it's real easy just to do your normal canine approach. You do your releasing incision between the canine and the incisor. You take your envelope flap back to that third premolar, do your flap, and then take the vestibular bone off like you would normally to extract that tooth, and see if you can get it all out. You know, a lot of times you can do that. Once you guys get used to doing that, you're quick. It's just as easy to go up there and take that bone off and see what that tooth root looks like, and either extract the whole thing or say, well, you know, right here, I can see the line of demarcation in my lateral approach, and so I'm just going to take this part where that front arrow is, and then the rest of it I'm just going to smooth the top of it, and then I'm going to close. And then you can confirm that grossly, obviously, and you may not have to go up all the way. You may get your burr up to where that arrow is and say, oh, well, this is resorbing tooth, this is bone replacing tooth, so I don't have to go any further. I'm just going to take this part and smooth the rest down. That's kind of how you approach that. But a lot of times, even though it looks like it's resorbed, like on those other two I just showed you, those you can get the whole thing out, and it's just as easy as doing a regular extraction. Here's one that there's a little lesion there, just starting on the mesial aspect. You guys even see that? It's kind of hard to see it even. It's right there. But total type 2 resorption with those striation effects. So that would be more like a true crown amputation. You do your normal, always do your normal approach for these canines, whether it's upper or lower. Because you're still taking the crown off, and you still have to get the gingiva over to cover the hole. So you're going to need a flap. You're going to need a flap as big usually as you would need to do your normal extraction. So that would be, you definitely take the bone down to here. This is another one where you've got a little vestibular bone expansion, but that's probably all you need on that versus normal. So what I'd like you guys to do in lab today, if you still have this tooth, some of you are buzzing right through your quadrants, so you may not even have this tooth left. But I'm going to show you how to do a partial extraction crown amputation on this tooth. This is the one that we do most commonly. So with this, before I forget and say it, this is what you want to look for in your exam room in your cats. This is usually the first tooth to go, the first tooth to show tooth resorption. So if you lift the lip up, you're not going to see that tooth normally because the tongue is going to be draped over that tooth. So you got to kind of manipulate the cat's mouth so that that tongue moves and you can see where that third premolar is supposed to be. If it's not there, that's an indication to talk to the owners about full mouth radiographs. So good take home for your exam rooms. You know, it doesn't matter what age the cat is, and we can see this starting at a couple years of age. Usually it's not until 6 or 8. But if we start to see that, we know that there's probably, if there's one, remember, there's 50% chance there's another one. So good indication for full mouth radiographs. So when we're doing the approach to this, what we want to do is just make a little incision, mesial and distal, on the marginal bone, just like we were going to do a envelope flap, only it's really only a millimeter or so on each side. And then we're going to use our periosteal elevator to open that tissue up like you see here so that your burr is not going to ding the gingiva, and you've already got enough mobility in that tissue to close it once you're done. So open it up so you can see it. Take your diamond football burr, a round burr, if you're real careful, a round carbide. You want to be careful with that because it's got those flutes in it. It can grab that gingiva and it can cause trauma to the gingiva. So you want to avoid that if you can. And then you can also, they also make a round diamond burr, and then a lot of times we'll use cylindrical diamond burrs versus the football burr, because you can see the football burr flares out in the center part, but that cylindrical burr is thin, so we can literally just see what we're doing on the margins really easily with that burr. So you can use that as well. And then once that's nice and smooth, confirm it radiographically, and then once you've confirmed that it's smooth, then you can go and either do a couple little simple interrupted sutures, or you can do a figure of 8 where you make a pass from, let's say, lingual to vestibular, mesial. So we make a pass here and then just make another pass caudal to it without taking the suture and tying it, and then tie it once into that little figure 8, and you're done. So quick, easy, and taking care of all the disease there. That will heal. You'll not be able to tell it in a couple weeks, and you're done. So pretty easy. So any questions about that? Tammy, is there anybody online that has any questions?
No questions so far.
Okay.
On Facebook.
Well, they had their chance because we're done. So when we're making decisions on this, we also have to take into consideration the tissue. Sometimes you'll have tissue that's really inflamed there, and you don't want to do our marginal excision like we do for the quadrant, because that's a small area. It's hard to get that back up. So you want to leave that inflamed tissue there too. You don't want to get aggressive, and just let it heal. Eventually it will do fine. It's just, you know, we don't like to suture inflamed tissue to inflamed tissue just from personal reasons, right? We want it to be all nice and look good, but we don't always have that option. We need to take into consideration that we're going to have a really aggressive flap to bring that normal tissue from the ventral to the dorsal to cover that. We'll probably have to do at least a bilateral releasing incision to bring that up after we excise that tissue. We don't want to do that. So just leave a little bit of the inflamed margin about as big as we did there, even if it's inflamed, and close it.